So I did my adult placement at Robert Wood Johnson University Hospital. The patient is a 63-year-old male who has a history of AFib, COPD, and sleep apnea. The patient was brought to Robert Wood Johnson Emergency Department via ambulance on 3/10/18 with shortness of breath and fatigue. The patient went into cardiac arrest in the emergency department and was intubated and put into the CCU on 3/10/18. The patient was extubated on 3/29/18, and the doctors consulted for a swallow eval. So when they consult for a swallow eval, we go over the whole chart that would have any significance to his swallowing: chest x-rays, head CT, intubation. We go over everything that could have an impact and look at the whole picture of the patient. So the chest x-ray on 3/10 showed small to moderate right and left pleural effusions with subjacent airspace disease. A CT of the chest done on 3/14 showed small bilateral pleural effusions and enlarged pulmonary vessels suggestive of CHF. Chest x-ray done on 3/15 showed no change since prior study, and a chest x-ray done on 3/20 showed ill-defined patchy infiltrate in both lung bases, which are worrisome for infectious pneumonia, and a head CT done on 3/25 showed no acute findings. Currently, the patient was stable in the CCU with an NG tube in place. So our initial bedside exam, the patient was Lurton-oriented ×3. We gave him 1 cup sip of thin. He showed immediate coughing and choking and had audible swallow. 1 teaspoon ×3 and 1 cup sip of nectar thick liquids, which he showed throat clearing with. And we gave him semi-solids, which was fruit cocktail, which he showed coughing and choking with. We recommended strict NPO status with alternate means of nutrition and hydration, and ordered a modified barium swallow study to further assess swallow function. The MBSS was done on 4/3. We gave him honey thick liquid by teaspoon ×3, premature spillage to vallecula. He had impaired reduction in laryngeal movement, repeated swallows, mild to moderate residue in vallecula and piriform sinuses, which reduced significantly with acute and spontaneous reswallows. On the Rosenbeck scale was an 8, so the contrast passes the glottis, visible subglottic residue remains, and the patient had an absent response, so silent aspiration. The patient was giving 1 cup sip of nectar thick liquids and 5 teaspoons. He had repeated swallows, reduction in laryngeal movement, mild to moderate residue in vallecula and piriform sinuses, which reduced significantly with acute and spontaneous reswallows. The Rosenbeck scale was an 8, again, silent aspiration. We gave him 4 teaspoons of puree. He had premature spillage to the vallecula, repeated swallows, residue in vallecula and piriform sinuses, and reduction in laryngeal movement, coughing, and choking. Rosenbeck scale was a 4, contracts vocal cords, no residue remains, penetration. We gave him 1 bite size of fruit cocktail and 1 piece of muffin. He had repeated swallows, reduction in laryngeal movement, and residue in the vallecula and piriform sinuses. Rosenbeck scale was 1, no aspiration, and the contrast does not enter the airway. So during the MBSS, we actually tried left head turn, chin tuck, which ended up being a useful compensatory strategy and showed that it reduced residue as well as protected the airway. So we gave him a diet of mechanical soft with nectar thick liquids by spoon only, using the compensatory strategy of left head turn chin tuck as tolerated. We also had a goal of the patient will complete laryngeal and pharyngeal exercises to improve overall swallow function with moderate to maximum verbal cues with 80% accuracy. And another goal was the patient will tolerate treatments of ice chips, nectar thick liquids, and soft solids, utilizing compensatory strategies with moderate to maximum cues with no overt signs and symptoms of aspiration 100% of the time. So immediately following the MBSS, we saw the patient for dysphagia follow-up. He wanted to eat, so we wanted to see how he was going to do with his meal. So the patient had treatment trials of mechanical soft consistency. He had mac and cheese and chopped green beans times 6, and nectar thick liquids by spoon times 5. The patient was instructed to turn his head to the left and chin tuck during each swallow and to take liquids by the spoon. Patient was educated and instructed on compensatory strategies numerous times but was non-compliant and intermittently required maximal tactile, verbal, and visual cues to use the strategies. The patient coughed 3 out of 5 times and throat cleared 2 out of 5 times with the mechanical soft solids, and throat cleared 2 out of 5 times with the nectar thick liquids by spoon. No other overt signs and symptoms of aspiration were noted, and no further PO trials were given. The patient was again educated on signs and symptoms and risks of aspiration and showed understanding. So after seeing all the difficulty he had with eating, we decided to put him back on strict NPO status and to do some exercises with him before we go through with giving him a diet. So we saw him again on 4-4. Patient was sitting out of bed in the chair. Patient had trials of ice chips with moderate to maximum cues to use the left head turn, chin tuck. He experienced double swallows and throat clearing 1 out of 10 trials using the compensatory strategy. Patient also had experienced coughing 2 out of 2 times with the ice chips. Patient was giving trials of nectar thick liquids by spoon times 6 and required moderate to maximal cues to use the chin tuck head left head turn to reduce risks of aspiration. The patient coughed 1 out of 6 times and throat cleared 2 out of 6 times with nectar thick liquids by spoon, and also had double swallows. No other overt signs and symptoms of aspiration were noted, and no further PO trials were given. The patient trialed exercises to improve swallow function. We tried the Masako, Mendelson, supraglottic, and supraglottic swallows, as well as the effortful swallow. And the patient was able to complete all the exercises with minimal cues, and we gave him written instructions so he could practice them on his own as well. So we saw the patient again on 4-6. Patient was sitting out of bed and chair. Patient performed the supra-subglottic swallow, super-subglottic swallow, and efferfoot swallow, as well as the Masako, when presented with oral swabs 5 times each. The patient attempted the Mendelson maneuver 2 times, but was unable to complete even with maximal cues. The patient was given 15 ice chips, 5 teaspoons of nectar thick liquids, 3 teaspoons of honey thick liquids, and 3 teaspoons of puree, using the head turn chin tuck compensatory strategy, while swallowing with moderate verbal and tactile cues. The patient coughed 1 out of 15 times with the ice chips, coughed 2 out of 5 times with nectar thick liquids, and 2 out of 3 times with purees, and no other overt signs and symptoms of aspiration were noted. So at this point, we continued the patient at NPO, except for ice chips as tolerated with direct supervision, using the compensatory strategies to reduce risk of aspiration, and we were going to follow up again. So we saw him again on 4-9. At this time, the patient removed the NG tube himself prior to our follow-up. The patient was giving trials of purees. He had 4 ounces of applesauce. He had nectar thick liquids by spoon times 3, honey thick liquids by spoon. He had 3.5 ounces. With moderate to maximal cues to use the left head turn chin tuck and to use double swallows to reduce the risk of aspiration. Patient had throat clearing 1 time per 4 ounces of purees, coughing 1 out of 3 times with nectar thick liquids by spoon, and no other overt signs and symptoms of aspiration were observed. So at this point, we recommended a puree diet with honey thick liquids by spoon only, give meds crushed with purees, no ice cream, no jello, full supervision with all meals and snacks to cue the patient of the left head turn chin tuck with a double swallow to improve airway protection and increase pharyngeal clearance. Patient also has to eat slowly, take small bites, sit up to 90 degrees, All of these strategies will reduce but not eliminate risk of aspiration, and the patient was educated that he still continues to be at risk of aspiration. So on 410, the patient was seen again for a follow-up. And the patient had trials of solids. The patient had 3 sugar-free shortbread cookies, nectar thick liquids by spoon, and honey thick liquids by spoon and by cup, using left head turn chin tuck with double swallows to reduce risk of aspiration. The patient coughed one time per 3 cookies, coughed 2 to 2 times with nectar thick liquids by spoon, and coughed 2 to 3 times with honey thick liquids by cup sip. No other overt signs and symptoms of aspiration were noted. So we advanced the patient to a chopped diet with honey thick liquids by spoon, still using left head turn chin tuck and double swallows. And we again educated the patient about safe swallow strategies, sitting up, small bites, small sips, that kind of stuff. So we saw him again on 412. We gave the patient 4 teaspoons and 5 cup sips of nectar thick liquids using head turn chin tuck, with minimal cues, and the patient had no overt signs and symptoms of aspiration. So we advanced his diet to a regular diet with nectar thick liquids using left head turn chin tuck, as tolerated, no straws, and the meds crushed with purees. We saw the patient again on 413. Patient was sitting out of bed and chair. Patient had 2 cup sips of thin liquids, using the head turn chin tuck compensatory strategy, and 3 cup sips without the strategy. The patient coughed 1 time with the strategy and 2 times without the strategy immediately following the swallow. Patient also had delayed cough after PO trials. So we continued the current diet of the nectar thick liquids and regular diet. And we saw the patient again on 416. Patient was very anxious to go home at this point. He had a hot dog and pizza for lunch and reported no difficulty swallowing. The patient was given thin liquids by cup sip, 8 ounces, and showed no overt signs and symptoms of aspiration. Patient was impulsive at times, taking large sips, but was responsive to minimal verbal cues to slow down. So at this point, we continued a regular diet as tolerated and advanced to thin liquids as tolerated, telling him to avoid straws, and educated on risks and signs and symptoms of aspiration. And on 417, the patient was discharged to home from Robert Wood Johnson University Hospital. So the rationale about intubation and swallow difficulties is that nearly 60% of patients who are intubated in ICUs experience dysphagia after extubation, and approximately 50% of them aspirate. So this study had an objective to determine factors associated with recovery from symptoms after hospital discharge for acute respiratory distress syndrome, survivors who received oral intubation with mechanical ventilation. So the conclusion was 1/3 of orally intubated survivors had dysphagia symptoms that persist beyond hospital discharge. Patients with a longer ICU length of stay have slower recovery and should be carefully considered for swallowing assessment to help prevent complications. So I also looked into the influence of chin down, chin tuck maneuver, and the purpose of this study was to investigate the influence of the chin tuck maneuver on the movements of swallowing related structures in healthy subjects. These results indicated that the chin tuck maneuver, including reduced horizontal movements of the hyoid bone, facilitation